Hello guys, very good evening. Sorry for to start a little bit early today. So today we're going to discuss a few things regarding your upcoming NEET exam. So I wanted to go with few old questions which you might have not experienced with, because this INICT had quite a few questions which came from AIMS 2014 and everything. So let's see, have a look at the old questions. Though it might look like an one-liner, the concept might be useful for you so that you can extrapolate, and if you have any questions in the upcoming NEET exam, you can attempt them. It's just based on the recent analysis of NICET. They did ask a few questions which are very, very old. Let's see and discuss. Hello Ganesh and good evening, Sneha. Fine. So a few things to start with. If you're a plus subscriber, you'll get all these benefits. If you're an iconic subscriber, you'll get the benefits of both Unacademy and Preparations. You can use any code, whatever you want. If you want to subscribe, there is 20% off for you as of now. You can do that. Light subscription and the free test calendar, do write them. And there are very specific batches, whatever you're focusing for. Without any delay, we'll start. I want you guys to comment here. They are going to be easy questions. Just comment whatever comes to your mind, right? You need not be right. That's fine. Completely fine. Just comment whatever comes to you. Okay. Let's go to the first question. Yeah, I'll mute myself for a couple of seconds. So comment whatever comes to your mind and let's see what's the right answer. The answer? Anyone? Very simple question. No, Dr. Ganesh. This is for NEET PG, so I think this might not be. Yes, otherwise. Lord Wisp with Angurash. 2D, C. Okay, we have a mixture of questions, right? Let's see which will be the right answer. The 45-year-old male suffering from recurrent and abdomen pain, fever, who succumbed to death after 10 days of hospitalization, right? I'm not going into these three images, so we'll come to the three images soon. We'll just look at the history. It's an elderly person uh, with the age alone, 45 years old. Which of these four options I can rule out? In other words, which of these four options is a finding seen only in a young person and not an elderly person? You can easily rule out dysplastic kidneys, right? So dysplastic kidneys is something which is going to be presenting with infancy. It will present with a non-functioning kidney, so I'll not be able to. It's not possible in a 45-year-old person. Now let's look at the rest of the history. I'm having a person with chronic abdomen pain and fever. This is important thing for me. Do you think a patient with an ADPKD will present as a fever, or they generally present as a renal failure? What do you think is a common presentation for ADPKD? It's going to be renal failure, right? An elderly person, maybe with an abdomen mass with a renal failure, I think of an ADPKD. So this is an unlikely possibility because they present with the fever, right? Who succumb to death after 10 days of hospitalization. We'll come to that later. A renal cell carcinoma, again, I'm not going with the image at all. This is how I want you to approach in a real exam as well. A renal cell carcinoma, do you think the patient presents with an abdomen pain and fever, or they present with a triad of mass, hematuria, and abdomen pain? They don't present with fever, right? Renal cell carcinoma, I might have an abdomen mass, might have a hematuria. They don't present the fever again. So because just based on the history, I can rule out option A, option B, and option B. This is what I want you to do in a real exam. It's just based on the history. I'll come to the microscopy, obviously. Like Saki said, that Saki has given us a clue there's a thyroidization appearance in the histology. We'll just come to that, fine. We have three images now. Without even an image, we can solve almost every image-based question which comes in NEET exam, because it is targeted at an undergraduate. Undergraduate should be strong in the history and not in the microscopic or an X-ray or an CT or an MRI, fine. But we have to read this as well. So if you look at this history, this first image, the gross image, most of you must have gone for ADPKD because it looked like cyst. As the only reason it looks like an ADPKD, right? If you carefully observe, I'm just going to zoom it. It might get little blurred. Ignore that. This is the outer surface of the kidney. In the outer surface of the kidney, are there any cysts? There are no cysts in the outer surface of the kidney, right? So when I don't have cysts in the outer surface of the kidney, my ADPKD is kind of ruled out. That's more than enough. But what I see in the outer surface of the kidney is you have scars. I do have scars here. There are irregular scars in the outer surface of the kidney. That's one thing for me. Again, a diagnostic. But on a cut surface of the kidney, there is something which look like a cyst. This part Are they exactly cyst, or can I call them an dilated renal papillae? They do look like a dilated renal papillae, right? You can see the pelvis, the ureter going like that, right? It's just a dilated renal papillae, right? The renal pelvis and renal sinus, they're just dilated renal papillae, right? So can this image grossly, can it mimic an, let's say, an case of your hydronephrosis? Because hydronephrosis starts with the dilatation of renal calculi, the renal pelvic calcium system. Then the entire kidney can be grossly dilated, right? So this is hydronephrosis. The only option which fits in hydronephrosis is option C. Though we ruled out and came to a diagnosis, I can come to a diagnosis with the gross imaging, microscopic imaging also. Second part of me is chronic pyelonephritis. Again, hydronephrosis doesn't present with a fever. It might present with a failure and an abdomen mass, that's all, or a pain sometimes. So when you look at two microscopic image, this is a very, very low power image. I want you to look at later on. But when you go to high power image, like whatever Saki said, this image, does it look like thyroid? They do look like thyroid, right? I have lots of proteinaceous material which is seen in the dilated tubules, right? This is a classical finding of thyroidization of tubules. Where do we see thyroidization of tubules? I'm sure you know the answer. In which disease do we see thyroidization of tubules? It is seen in case of chronic pyelonephritis, right? So we see in case of chronic pyelonephritis, thyroidization of tubules. Even in the low power, if you see on the top part, this top part, you have lots of tiny pink colored dots. Those are the thyroidization of tubules in a very low power that you need not require to identify. But yes, definitely this image, the classical case of a thyroidization tubule. It looks like a colloid, so we call them thyroidization. Okay, let's have a quick look about why I have this thyroidization. Then we'll definitely go to the next one. When I say chronic pyelonephritis, I will go to our basics. What is the defining feature or hallmark finding seen in for any chronic inflammation? Be it tuberculosis or pyelonephritis, what do you think is the hallmark finding for any chronic inflammation in your body? Any chronic inflammation has only one thing, which is tissue destruction, healing by fibrosis, right? That's the hallmark for every chronic inflammation in my body. So when I'm having chronic pyelonephritis, where the tubules are destroyed. So if a tubules are destroyed, dental Q granuloma is something which I see in microscopy. When I say hallmark finding or the characteristic finding, we go for the template of tissue destruction and healing by fibrosis, right? Here in chronic pyelonephritis, my tubules are going to get destroyed. So what do you think will be the function of a normal renal tubule, a proximal convoluted tubule? What is the function of a proximal convoluted tubule? Simple. Reabsorption, right? So when my proximal convoluted tubule is getting damaged, and I say the function will be lost, which is the reabsorption of the tubule will stop. If the reabsorption stops, all the proteins which are supposed to be reabsorbed stays back in the tubule. That's what I'm having like colloid-like appearance, right? So there's nothing but a decrease in the function of my proximal convoluted tubules, which results in a decreased protein absorption. It will have decreased absorption of many things, including protein. This over the period of time accumulates because it's in chronic inflammation. It's going to go on accumulating. That over the period of time gives an appearance of a colloid. So that's why we call it, it looks like thyroid. So we use the term thyroidization of tubule, right? Okay. That's the explanation behind thyroidization so that you don't forget anytime soon. We'll go to the next question. I want you guys to comment. It's fine if you're wrong. These are few older questions of NEET and AIMS. So if it comes in the exam, it should be of help. I'll mute myself for 30 seconds, comment on the answer. Answer? A has gone with A. Any other to it is an AIMS PO here. Okay, so we have multiple answers. Most of them you have gone with either 3 or C or B, right? Some of you A as well. Okay. Whoever answered B, molecular classification of breast cancer is based on HER2 and estrogen receptor status. That's what we do in a real life, right? The ideal way, how do we classify breast cancer molecular basis is based on gene expression profiling. This is a poor man's method. What we do in our hospitals is IHC. IHC basis of ER, PR, and HER2/neu. That's not the way in an ideal scenario your breast cancers are classified. If it's an MCQ, I want to go to an ideal scenario. Have you seen any time in Robbins few images with red color, green color? You must have had boxes like this with multiple red, green, red, green. That's gene expression profiling. You have multiple of expressions, right? So it's gene expression profiling is the ideal way on which the base of molecular classification of breast was done. But for us, since I cannot go for a gene expression profiling always, we use its expression. The expression is obviously the protein receptors, right? I look for the proteins. An ideal way is obviously gene expression profiling. If it's not there in the option, just go for HER2/neu or ER status. If gene expression profiling is there in the option, please go for gene expression profiling. That's any day better than your IHC based HER2/neu and ERPR, right? If I'm going to give you two options where the patient is not having a problem with money or anything, what will you choose? IHC for HER2/neu or you'll choose fish for HER2/neu? There's no problem economy wise. If the person wants to go for the best test, you'll choose IHC for HER2/neu or fish for HER2/neu. Everyone here will choose fish, right? Because fish is any day better than IHC. So IHC is the protein. Fish is talking about the gene expression, right? So gene expression is more important for me than the protein expression. So gene expression profiling will be the answer and not the protein expression, right? Just in a practical scenario for you to apply. This is an old PYQ. Do not write this. So we have studied lots of them, right? So since we are in molecular classification of breast, ask you a few questions regarding that. Let's see if you can answer. I'm sure you can answer. You must have heard about multiple types of molecular classification, right? That luminal A, B, and everything. Of the luminal A, B, HER2/neu, enriched, and everything, which is the commonest subtype? The commonest subtype of molecular classification of breast. What do you think is the commonest one? Commonest one is luminal A, right? Luminal A is obviously the commonest type, right? So luminal A is the commonest type. Of the all options, which of the molecular subtype of breast cancer has the best prognosis? Is it triple negative is not the common one. Luminal A is the common one. And obviously luminal A has the best prognosis as well. Yes, it has the best prognosis. I'm just going to end this question discussion with only one thing. I'm going to tell you the ERPR HER2/neu status of a person, and I want you to identify whether it is luminal A, B, or HER2/neu or your triple negative cancer. A patient came with a breast cancer. ER was positive. PR was positive. HER2 was negative, and Ki67 was, let's say, 40%. Where will this go under? Luminal A or luminal B or HER2/neu enriched or triple negative or basal like? What subtype of molecular classification will come under? It will come under luminal B, right? It will not come under luminal A. It will be coming under luminal B. The only reason I gave this example is don't make this mistake in a real exam. It will not be under A. The reason being, most of you, when you look under luminal A or luminal B, you look at these two only. If you have a Ki67 which is more than 14%, even I have ERPR positive and HER2 negative, it goes under luminal B. Luminal A and luminal B, there are two things. Luminal A stands for ERPR positive. I'm just writing ER positive just for the thing. HER2 negative, and Ki67 should be less than 14%. If it is more than 14%, it goes to luminal B. Luminal B has two things. Either it can be ER positive, PR positive, HER2 positive. If all three are positive, I don't care about Ki67. It goes under luminal B. If ERPR is only positive, and if Ki is more than 14%, it goes under your luminal B. It doesn't come under luminal A, right? So please be careful with this. Other things in molecular classification of this is very simple. HER2 alone positive, HER2 enriched, everything negative, triple negative, right? Luminal B has two things. If Ki is given, please give more emphasis on that. Right? Okay. Let's assume for an instance, a patient has a BRCA positive cancer, BRCA positive cancer. There are two leading questions here. BRCA1 positive cancers generally fall under which of the categories? A, B, HER2 enriched, or your triple negative? In general, may not be always the right one. Most of the BRCA1 positive tumors fall under triple negative, right? So BRCA1 positive tumors, most of them, again, it's not a dictum that it should be triple negative. They can be ER/PR positive, also, but generally they'll be triple negative, right? One more thing, if a person has a BRCA mutation, right, BRCA1 mutation, tell me which of the microscopic subtype is more common. Like, is it ductal carcinoma, or an lobular carcinoma, or an medullary carcinoma, or a metaplastic carcinoma? Which of them is more common in BRCA1 mutation? Again, it's not always the dictum it should be present. In general, BRCA1 mutations are the medullary carcinomas are more common with BRCA1 mutation, and medullary carcinomas are also triple negative. We'll just look at the terminology and see if we can extrapolate this to many other features, whatever you read in your surgery or in your pathology. When you say medullary, what do you mean by medullary? What does the term medullary mean? What does medullary mean in general? Okay, cortex medulla. Which of these two is softer? I'm just going to erase the other things just for us to read this beautiful concept. Cortex or medulla, which is soft? Medulla is soft, right? Cortex is not soft, right? So amongst the cortex and medulla, medulla is soft. So when I term any tumor medullary carcinoma, which means it's a softer tumor. In general, for every cancer, what you must have read in your surgical textbook of class, you must have read that on palpation, it should be hard. Anything hard on palpation, I think of a cancer. That's what clinically you're going to diagnose. All the cancers which are named medullary carcinoma are softer. They're not firm. They're not firm because they don't have much of desmoplasia. In general, medullary carcinomas will have pushing margins, not infiltrative margins. The same true for medullary carcinoma breast as well, right? If you have a softer tumor, or maybe to some extent firm, not hard, on clinically, if you're a surgeon or an intern, you are palpating a breast mass which is not hard, what do you think of? Benign or malignant in general? Without the understanding of medullary carcinoma or no microscopic evidence, what do you think of? Generally, think of a benign condition, right? Generally, we think of a benign condition if it is soft. Keep this in mind. If it is medullary carcinoma of any organ, on palpation, it will be softer only. It will not be hard. The reason I term the medullary carcinoma thyroid is because it's soft in nature. Right? You just keep this in mind. So if you're going to become a surgeon, it might be useful for you to distinguish, okay, an elderly person, it's not fitting into benign. Think of medullary carcinoma clinically. You can suspect them clinically as well. Read through the question. I'll mute myself for a few seconds. On the answer. So D. Vikram has gone with D. Anyone else? D as well. D. Okay, before going to the question, there's only one history given which is might help me to come to a diagnosis in the question. I'll go retrospectively, we'll go from the options, right? Uh, a lipidic pattern of arrangement of neoplastic cells. Which of the lung cancers is a question on lung cancer? Which of the lung cancers do you think will have the finding mentioned in option A? Lipidic pattern of arrangement. You must have heard the lipidic pattern. It is more commonly seen in adenocarcinomas, right? It can be seen in adenocarcinoma in situ or adenocarcinoma invasive. I have the lipidic pattern of arrangement. Lipidic means let's have alveoli here. It's arranged in the form of a line, right? Okay, as bronchular alveolar carcinoma was the older term. It's been renamed as adenocarcinoma in situ. So both adenocarcinoma and adenocarcinoma in situ might have a lipidic pattern of growth, fine. Let's go to the second option. Contains all three germ layers. Which of these tumors do you think will contain all three germ layers? Be it lung, be it mediastinum, which of the tumors do you think will contain all three germ layers? All the three germ layers, the classical findings seen in teratoma, right? Teratomas have all three germ layers. Perfect. Next, abundant osteoid matrix formation. Though it's not the correct description for it, I need few more information to come to a right diagnosis. But in general, when you have an abundant osteoid matrix formation, I either think of an osteoma, which might not be from the lung. If it is metastasis of an osteosarcoma, that's also a possibility. But I need comment on pleomorphism and others to find out. In general, since we are talking about lung cancers, I would prefer mets of osteosarcoma because I am sure you know that osteosarcoma, one of the commonest site of metastasis is lung. Right? And osteoid, malignant osteoid formation in lung, I'm going to think of a metastatic osteosarcoma. Right? Option 4, small round hypochromatic cells with hypochromatic nuclei with a nuclear molding. Which of the lung tumors do you think will have this classical description? It's mostly small cell carcinoma. Have small cell carcinoma, have the classical description. Yes, I'll go with neuroendocrine or a small cell carcinoma. Anything is fine with me, right? Again, it's based on mitosis presence or not, necrosis present or not. I'll call it carcinoid, atypical carcinoma, or small cell carcinoma. Okay. So now we'll go back to the question. A 65-year-old person. I just want you to know how to differentiate him. If it is a 65-year-old person, you are seeing the patient in real life. Which of these four options you will rule out? It's never possible in a 65-year-old person. Which of these things do you think is very, very rare or impossible to find in a 65-year-old person? Can we expect teratoma in a 65-year-old person? In general, you must have studied teratoma in your male and female genital tract. Teratomas are not something seen in 65-year-old person, right? It's generally seen in, let's say, 20 to 40 years age group, right? So with age, I can rule out teratoma. Why that's very, very important is teratoma happens in the lung or mediastinum. It happens in the mediastinum, right? So can teratoma cause distal bronchiectasis? Because it's a mediastinal mass which can keep on increasing in size and can press the bronchus. Can it cause bronchiectasis and recurrent pneumonia? That is a possibility, right? So teratomas from the mediastinum can compress on the bronchus, can compress on the lung parenchyma and cause these findings. It's still a possibility. The only way I can rule out teratoma with the above history is age. 65-year-old teratoma is not possible, right? Other three things are still possible for me. It's an adenocarcinoma. Where do you think adenocarcinoma is common? If I have a lung, in normal lung, where do you think you'll see adenocarcinoma? Let's say there's a lung, ignore my bronchus. Adenocarcinomas are common in the center of the, near the hilum, or it's common in the periphery. Adenocarcinoma is generally common in the periphery, right? I'll have adenocarcinomas in the periphery. It's not a tumor, it is common in the hilum, right? But if my question says that I have a whitish tumor located in the central bronchus. White doesn't help me because most of the tumors on the gut surface are white in color only. Adenocarcinomas are peripherally located tumors, they're not centrally located tumors. It's simple. Can I say alveoli is in the form of a gland? When I see an alveoli looks like this. Can I say it appears like a gland? Yes, right. So when the alveoli has carcinomatous transformation in a microscopy, I call it an adenocarcinoma. That's all. The alveoli in a normal lung, I will see in close to the hilum or in the periphery. In the periphery, right? So since alveoli is common in periphery, adenocarcinomas are something which is neoplastic transformation of the alveolar epithelial cells. So I'm going to see them in periphery, right? So that also is not possible in this question. Option D, C, metastasis. Mets is also a finding seen in the periphery only. Mets are multiple peripheral well-defined nodules. That's a classical description of Mets. Again, not a possibility, right? So option A and C is not possible because they are not seen in the center of the lung, not a hilar lesion. Option B is not possible because I don't expect that in a 65-year-old person. The only possibility here is your small cell carcinoma or any neuroendocrine tumor. Any neuroendocrine tumor happens in the center of the lung only. What is the other tumor which can happen in the center of the lung or the hilum of the lung? Like Satwik said, is one more tumor which is possible in the hilum. This squamous cell carcinoma, right? Squamous cell carcinoma is also possible in the hilum. So is your neuroendocrine tumors as well. Okay. Again, an old question. I'll keep quiet for the next 30 seconds. I want you guys to comment. Whatever comes to your mind, you can answer. option A. Good. So I must have seen these questions. These are older AIMS questions. It's not a new question at all. So tightly arranged cohesive clusters and discohesive bar nuclei. Again, we'll go retrospectively like what we did for the previous question because I want you to understand whatever is there in the options rather than coming to a correct answer. So atypical, just one atypical cells with myxoid changes and mitotically active stromal cells. What do you think option D will fit into? All these are breast parenchymal lesions. What do you think option D will fit into? Atypical cells, myxoid changes, and mitotically active stromal cells. Which of the breast tumor will fit into option D? Cases? It's a problem in the stroma. Can you tell me, when I say carcinoma, I might not have a mitotically active stromal cell, right? So when the emphasis is more on stromal cell, I want you to think of something stromal lesion in the breast. Can anyone tell me what stromal lesion in the breast can become malignant? Yeah, there's a possibility of phyllodes. I'm not saying it will only be phyllodes. That's one possibility, or it could be any sarcoma. It's a stromal lesion, that's all. It's a malignant stromal lesion. Phyllodes can be benign, borderline, and malignant. It's still a possibility. Or it could be any sarcoma because breast can have multiple sarcomas. It can have angiosarcoma, fibrosarcoma. It could be any of the sarcomas. In an FNAC, I can give only differential diagnosis. I cannot give a perfect diagnosis, right? Option C, sheets of plasmacytoid cells with background lymphocytes. Whenever you look at this plasmacytoid appearance on an FNAC of breast parenchyma, think of lobular carcinoma. That's again a differential diagnosis. That's one differential diagnosis. Second differential diagnosis of medullary carcinoma. Plasmacytoid appearance of a tumor cell is commonly seen in medullary carcinoma of breast as well as your lobular carcinoma of breast. On an FNAC, I cannot come to a diagnosis, only differential. And option B is discohesive population of pleomorphic ductal cells. It's clearly mentioned it's pleomorphic ductal cells. My only possibility here is infiltrative retinal carcinoma. Option A, like you guys, most of you guys answered, there's a tight cluster of cells, which means there is no discohesion at all. Tightly arranged ductal epithelial cells in breast parenchyma means a benign lesion. Might be a fibroadenoma, can sometimes be a fibrocystic disease also. But in general, a non-tender mobile mass from the breast most likely be a fibroadenoma. How many of you want to become surgeons in future? Keep saying this to every aspiring surgeon, and I hope you will implement whatever you read during entrance examination because that's more important than scoring a mark. FNACs of breast has been disregarded in most of the abroad countries because the diagnostic sensitivity and specificity is very, very less. So if you suspect carcinoma on a clinical examination for a breast lump, please do a biopsy, do a core needle biopsy, don't do an FNAC. Because if it is a carcinoma, am I right in saying that you cannot treat the patient without ERPR hernia? Can't. I do want ERPR hernia, so please don't go for an FNAC. In FNAC, I cannot do an ERPR hernia. I'll give kind of an wishy-washy diagnosis and advice for a core needle biopsy. If it's a cancer, I need core needle biopsy. I cannot diagnose on an FNAC alone, right? So please don't do that alone. Otherwise, it's completely fine. Even if it's fibroadenoma suspected clinically, I would say excise the tumor because fibroadenoma can be easily picked up clinically, right? If you want, do an imaging, ultrasonogram to prove it is not infiltrating, not having any calcification, just remove the tumor. Next question. I'll mute myself for a few seconds, read the question and give an answer. So A, D, A, C, quite a few overlap. I hope everyone read wrongly. If you didn't read wrongly, please read the questions properly. So that's something which is wrong for us, right? Wrongly, all except negative statements, not uncommon. These are few things which might pull you your, which might lead you to a silly mistake in a real exam. Please be careful about it, right? Desmins and carcinomas. Is this statement right? Do we see desmin in a carcinoma? We had a PYQ where in a rhabdomyosarcoma, Desmin was positive. If you remember that a child with an eye lesion, which is positive for Desmin, and says your answer is your rhabdomyosarcoma. The rhabdomyosarcomas, Desmins are positive in sarcomas, not in a carcinoma. It's wrong. Desmin is positive in a sarcoma. It's not positive in a carcinoma. Vimentin. Can I say Vimentin is a IHC for sarcomas? It is right. Second option is absolutely correct. Vimentin is an IHC used for sarcomas. It's a very sensitive marker, not a specific marker at all. Leukocyte common antigen, right? So leukocyte common antigen lymphoma, because quite a few of you wrote option C as the wrong match. This is not your Kala. Kala positivity is totally different from this. Leukocyte common antigen stands for LCA. Can any one of you here tell me what is the what's the CD marker number for LCA? It's CD45. CD45 is a tumor marker seen for lymphoma. This you definitely know this. If I can kindle your memory a little bit, you must have definitely read about nodular lymphocyte predominant Hodgkin's lymphoma, NLPHL, the popcorn cells. The popcorn cells, RS cells of popcorn cells, they are positive for what two markers? They're positive for CD45 and CD20, right? CD45 is a leukocyte common antigen. It is LCA. CD10 is something different, which is called a scala. So if I have the question reframed as CD10 and lymphoma, will it be positive or negative? Or is the correct answer or wrong answer? Will CD10 be positive in lymphoma? Yes or no? Will CD10 be positive in lymphoma? It will be, right? CD10 is also positive in lymphomas. This also is not a wrong statement. This is absolutely correct statement. You must have read follicular lymphoma, Burkitt's lymphoma, where CD10 and BCL6 are germinal center markers, right? Any tumor which comes from germinal center, be it follicular, be it Burkitt's, they'll be CD10. It's not a tumor seen only in your ALL. It's a tumor marker seen in lymphomas also, right? So whatever be the option, be it CD10 or be it LCA, both of them are positive in lymphoma. Endometrial CX is for carcinoma, is it? Not positive in endometrial carcinoma. If you want to extrapolate CD10 to endometrium, it's positive in endometrial stromal tumor. It's not positive in endometrial carcinoma, it's positive in endometrial stromal tumors or endometrial sarcoma. It can also be positive in endometriosis. The glands will not be positive, but the stroma of the endometrium will be positive for CD10. And option D, melanoma, as well as your SN is also positive. So that's the correct answer. So the wrong answer here is Desmin and carcinomas, or option C. So please look for these things. If you miss them, it might cost you a little bit. Silly mixes should become bare minimum. So please use the 10-second rule. Do not write any option, any question in the real exam for the first 10 seconds. And help you to minimize lots of silly. Right? See the question. Okay, option answers. It's a very, very simple one. An Afro-American male child present with sickle cell anemia. Which of the following is an etiology? Simple one, right? Okay, more the question, more basic and more easy it is, you guys are having a little bit of more trouble, right? The sickle cell anemia. The mutation of sickle cell anemia is very commonly known, right? It's the beta globin 6 chain glutamine to valine. That's a mutation seen in sickle cell anemia, right? Glutamic acid to valine, right? So sickle cell anemias do have point mutation. The point mutation, which means where one of the nucleotides is being replaced by another nucleotides. So what happens is your glutamic acid changes to valine, right? A point mutation can never be a frame shift mutation. It's totally different. You have to understand what is a frame shift mutation. I'll tell you what is frame shift mutation so that you don't make mistakes in future. the simple single nucleotide mutation. That's all. A change in single nucleotide, which results in change in an amino acid, which gives an altered sense. So we call them an missense mutation, right? Sickle cell anemia is a classical example for a missense mutation, right? Let's see what's in frame shift mutation. We'll go with an example. Let's say that I'll just erase this for a second. Option A is the right answer here, not option B. Fine. Let's say this is an DNA. We have ATCG, ATC, just for instance. Okay? Let's assume, for instance, that this E and C is getting deleted in a person. So if I'm going to write, it's going to be AG, ATCG, ATCG. I'm just drawing a random nucleotide just for a continuation, right? So if I'm going to have, this is the normal DNA, this is a patient's DNA, the nucleotide sequence. If the first normal DNA is getting converted to an mRNA and then to a subsequent protein, the codon is always triple nucleotide. If you remember biochemistry, I read that all the codons are three nucleotides and they don't have a punctuation, they don't have a comma, they're continuous, right? So here it's going to be ATC, GAT, CGA, T, and so on. That's how it splits. But when you go to the second one, it's AGA, TCG, ATC, G, and so on, right? That's how it splits. So here, can I say, compared to the first one, comparing that to the second one, the reading frame or the three nucleotide reading frame has been shifted? It is, right? So the reading frame is getting shifted in this mutation. So we call them a frame shift mutation. It's there in the name. Everything what you need to know will be there in the name. The reading frame gets shifted, so we call them a frame shift mutation. So now looking at this, is frame shift mutation a single nucleotide mutation or is it deletion of a nucleotide? Where do you see frame shift mutation? In transition transversion or in a deletion? Frame shift mutations are obviously either it could be a deletion or it could be an insertion. Either deletion of two nucleotides or one nucleotide, it should not be three. Deletion or an insertion of anything will result in a frame shift mutation. Right? Let's assume you must have read about cystic fibrosis, right? What do you think? What is the commonest mutation in cystic fibrosis? I'm sure everyone knows that. The commonest mutation in cystic fibrosis. You must have read this for sure. Delta F508. You must have heard that, right? So Delta F508 is the most common mutation seen in cystic fibrosis. So which means it's a deletion of phenylalanine. The entire phenylalanine, the three nucleotides gets deleted. So if three nucleotides gets deleted, will there be shift in the reading frame or not? We know what is a frame shift mutation. We're just going to apply something to make a concept more stronger. When there's a three nucleotide deletion, will there be an alteration in the reading frame or not? There'll be no alteration in the reading frame, right? Three nucleotide deletions do not cause an alteration in the reading frame because one amino acid is entirely taken. So that's not a frame shift mutation. Frame shift mutation should have either one or two nucleotides or in multiples of 1 and 2. It should never be 3 because if it's 3, one amino acid is removed, the reading frame is not getting altered, right? Just keep that in mind. For that, I'll go to the next question. Okay, I'll mute silent myself for a few seconds. Comment on the answer. Just Pratha has said option B. Anyone wants to add to it? Again, the 65-year-old person diagnosed with the lung cancer with a paraneoplastic syndrome of due to increased calcium. The first question is, if lung cancer is causing hypercalcemia, what is the diagnosis? Microscopic diagnosis. Is it squamous? Is it adeno? Is it small cell? Is it carcinoid? What will be the diagnosis? It will be squamous cell carcinoma, right? In general, Squamous cell carcinomas are the one which will have an increased pa- calcium in case of paraneoplastic syndrome. Snega, medullary carcinoma thyroid will not be there in lung, right? I'm not talking about thyroid lesion. It's a squamous cell carcinoma of the lung. This is a paraneoplastic syndrome. So if there's a paraneoplastic syndrome, by squamous cell carcinoma or any most of the cancers which cause paraneoplastic syndrome, you must have read them like this: PTHRP. PTHRP stands for parathormone related peptide. This is the RP. They just expanded that. That's all. PTH will not be elevated in any of the paraneoplastic syndrome. It will be only PTHRP, right? I'm going to tell you a definition of a paraneoplastic syndrome and I'm going to give you a statement. Tell me whether it's correct or not. When I say paraneoplastic syndrome, let's assume a patient is having parathyroid adenoma. Can I say a parathyroid adenoma patient also will have hypercalcemia? Will they have or not? Simple patient of parathyroid adenoma. Will there be adenocarcinoma? Sorry, will there be an increase in calcium levels? Yes, there will be increase in calcium levels, right? Because one of the commonest cause of hypercalcemia is parathyroid adenoma, right? So here I'll have increased calcium levels. So this increase in calcium levels or hypercalcemia in case of parathyroid adenoma, can I call it a paraneoplastic syndrome or not? That's a simple question. Can I call it or not? This is due to increase in PTH. Can I call it? No, right? Cannot call it. This is not a paraneoplastic. If it's due to the tumor origin, I cannot call it a paraneoplastic syndrome, which means you have an ACTH secreting adenoma, the pituitary. Cushing syndrome is not a paraneoplastic syndrome. It's a symptom of the cell. Because parathyroid glands normally secrete parathormone. When you have a tumor, they're going to secrete them excess. So you cannot call it a paraneoplastic. The definition by what defines paraneoplastic syndrome: group of symptoms and signs which cannot be explained due to the function or the anatomy of the tumor. And I can call it paraneoplastic. But a normal lung parenchyma will not secrete PTHRP. The cancer secretes them. If a patient with small cell carcinoma of the lung secretes ACTH, that is ectopic ACTH secretion, I call them paraneoplastic. Right? That's the definition, and that's how we define paraneoplastic syndrome. Right? So we'll try to challenge whatever we know already, right? We learn, we unlearn, we relearn. That's what makes us the best. Let's say the statement which I'm going to write next, tell me whether it's true or false. That's all. A patient with the renal cell carcinoma will have polycythemia vera. Is that a paraneoplastic syndrome or not? Must have read them for sure. Can I call this paraneoplastic syndrome or not? Yes, yes, paraneoplastic. You must have definitely read. You must have read the statement. Maybe you were contemplating for the reason that whatever we read just now, it's exactly opposite to that, right? All of you must have read this statement. It's an MCQ, right? Renal cell carcinoma patients will have paraneoplastic syndrome, polycythemia vera. It is paraneoplastic. So I need to explain why. It is correct, but I need to explain why, right? So understanding something in depth will help us avoiding confusions. This INACD had a question, right? In renal cell carcinoma, there are multiple correct answer questions. Renal cell carcinoma, the origin of renal cell carcinoma, let's take the commonest one, clear cell renal cell carcinoma. What do you think is the origin? Do they come from interstitial cells or they come from proximal convoluted tubule? The origin is PCT, right? The origin of renal cell carcinoma is proximal convoluted tubule. So if it originates from proximal convoluted tubule, in a normal person, do PCT secrete erythropoietin? Do they secrete erythropoietin? They don't. Normally, PCT has no role in erythropoietin. Normally, erythropoietin either comes from interstitium of the kidney or it comes from the juxtaglomerular apparatus. PCT doesn't secrete. Now look back at this definition of paraneoplastic syndrome. A symptom which is not related to the origin of the tumor. It is definitely paraneoplastic, right? It is paraneoplastic. Kidney secretes erythropoietin. If you look into the kidney, it's not the PCT which secretes, it's the interstitium or the juxtaglomerular apparatus, right? So polycythemia vera in renal cell carcinoma is undoubtedly a paraneoplastic. Just remember this. This is not a wrong statement. This is absolutely correct. For next one, a very, very simple question. Answers? A, B, infective endocarditis. The simple one. Please don't make mistakes in these. You shouldn't make a mistake in these. They're very, very simple ones. Okay, it's bulky friable vegetations. There is only one vegetation in the cardiac tissue which is friable, which is bulky, which can destroy the entire valve. This is undoubtedly infective endocarditis. Libman Sachs is not bulky. Libman Sachs is not friable. Only thing, see, amongst the vegetations, infective endocarditis has few unique features. This is the only aseptic thing. This is the only thing which has the organism. This has the organism, so it can cause an septic embolus, if you remember. These are the only vegetations which can have an embolic episode. They are friable, they are very, very fragile. They can break apart, go into the brain, and can cause brain abscess, or can go into any part of the tissue. If it goes and settles in another blood vessel, it can cause myocardial aneurysm, right? These are the only vegetations which can destroy the valve. There are no other vegetations of the four options. Lippmann Sachs doesn't destroy valve, rheumatic carditis doesn't destroy valve, NBT doesn't destroy valve. And all of the three are aseptic. They don't have any organisms. Lippmann Sachs endocarditis, in which condition do you see them? We'll just see what are they made of. You tell me the condition, you're going to tell me what they're made of. Lippmann Sachs is seen in SLE, right? I'm sure you know that. So if it is seen in SLE, what do you think the Lippmann Sachs vegetations are made of? In Lippmann Sachs endocarditis, what are they made of? You know the pathogens of SLE, so you should be able to answer what they are made of. The same thing we're going to go for the other things as well. It's in lupus. Yes, it is seen in SLE. What is the pathogens of SLE? Simple pathogens. What is that? It's immune complex, right? It's immune complex, circulating immune complex deposition. This Lippmann Sachs endocarditis is made of the same antigen antibody complex. That's all. Simple. I know the pathogenesis. That's what is going to get deposited. Just immune complex, fine. NBT. I'm sure you know the full form of NBT. I'm just saying just for a confirm. NBT stands for non-bacterial thrombotic endocarditis. So what do you think are the vegetations made of an NBT? Again, you know the disease. You might know a few examples as well. Tell me what they are made of. The answer is in the name. Most of the answers will be in the name. It's non-bacterial thrombotic, right? It should be made of thrombus. It's nothing but thrombus. It's non-bacterial thrombotic endocarditis, right? So it has to be made of thrombus. Microscopy, what I'll have is a thin thrombi. You can see NBT in DICs. You can see NBT in your Apla syndrome. You can see them in pancreatic cancer, right? It's made of thrombus. Rheumatic carditis, I'm sure you know, it's an immune-mediated destruction. There also I'll see antibodies only. Though it's not an immune complex, I'll see antibodies in rheumatic carditis as well. And infective endocarditis, obviously the infectious organism and the damaged tissue, right? Great. This is an image from Robbins. This might be very, very useful. Might come handy on a last minute if you want to have a quick look. Look at these two, NBT and rheumatic arthritis. Both of them will be present in the lines of closure, which is at the junction of your chorda tendineae and your valve, right? These are seen in the lines of closure. These both. LSE stands for Lippmann Sachs, which is seen on both the sides. When you have any vegetation seen on both atrial side and the ventricular side, you're going to go for Lippmann Sachs endocarditis. Infective endocarditis is the only one which can destroy it. If both of them are present on the line of closure, the bigger one is NBT. They are very, very tiny. They are very, very tiny. And because of the tiny nature, they are also being called as verrucae. It looks like a verruca vulgaris. The warts, they're extreme tiny things. NBT is a bit bigger. It's a thrombus. It's slightly bigger than your hepatic vegetation, right? And lymph sacs can be seen on the side. A simple question. Sure, you know the answer. Options, answer. Comment on whatever comes to your mind. It's a very simple one. The routine gross staining done for myocardial infarction. Most cases of myocardial infarction, what we do is we cut at triphenyl tetrasodium chloride, and the normal color of heart is going to be reddish in color, right? It's going to be brick red or red in color. That's a normal color of triphenyl tetrasodium chloride, right? It's a very simple thing. When there's an MI, this is completely a gross staining. This is not a microscopic staining. So don't mistake that. I cannot do a TTC staining on a microscopy. It's undoubtedly a gross staining. So when you take myocardial infarction, in microscopy of a myocardial infarction, what type of cell death we'll see? We'll just give reasoning for why TTC changes color. What is the type of cell death seen in myocardial infarction? Cell death? You'll see necrosis, right? So obviously, it's going to be coagulative necrosis seen in myocardial infarction. Whenever the patient has necrosis, be it heart or be it anywhere in the body, there will be definitely damage to the cell membrane and the intracellular contents come outside. So here also the same thing happens. So there will be an increase in LDH locally outside the cell because of the cell membrane rupture. So when a person adds TTC, triphenyl tetrasodium chloride, to a gross staining, this LDH, if it is present, that's in a necrotic tissue. In a normal tissue, the LDH will be intracellular. It will not be extracellular. In normal tissue, what happens is there is no change in color. It appears the same, red in color. But since the necrotic tissue has LDH excessively present outside the cell, that changes them into a pale yellow color. This is the LDH which is changing the triphenyl sodium chloride to a pale color. That's reason grossly I can even see them a little bit different, altered color. Let's assume it's a patient with a very old infarct, very old infarct. For a patient with an old infarct, I'm having a scar tissue. If I add TTC, triphenyl tetrasodium chloride, grossly over a scar tissue, do you think it will absorb or it will not absorb at all? Will the stain be absorbed inside the cell or not? It's an old infarct, a complete scar tissue. Scar tissue is an dead tissue, not a live tissue. If I'm going to add it grossly, will a scar tissue stain? Not absorb. When it's not going to absorb, it will look completely white in color. The image from Robbins, I'm sure you must have seen this. This part, whatever is being red, is normal. This part, whatever is being the pale yellow, is the infarcted area. This part where you see the arrowhead with a white color, that's an old scar. The scar tissue is not going to take up anything. It looks pale, like anything. Here also I can see a tiny bit of scar tissue here. So scar tissue extremely pale in color, extremely white in color. Can anyone tell me what this is? Since I have one more color seen in the image, I just want you to zoom it if you want. Just tell me what do you think that is? Any guesses? It can be right, it can be wrong, whatever comes to your mind. That's an area of hemorrhage. That's an area of hemorrhage. It's seen at the junction. Generally, what happens is at the junction of the infarcted and the normal parent, there'll be a little bit of more hyper congestion happening. That's area of congestion or hemorrhage. That's the reason it is. It looks like an altered blood, blackish in the penumbra region. A little bit of more congestion, more hemorrhage-like area. That's what you can see in blackish. They might not ask it. If they ask, you should be able to answer it. This is the last for today. Comment on the answer. Yeah, lipofuscin is a microscopic appearance. not be easily appreciable in a gross. Answer. Classical one, right? The very classical history wise, it's bit might be a bit difficult, but on a gross imaging wise, it's very simple to know the answer. The 30-year-old person, adnexal pain and adnexal mass. I would say almost all four of them will present with adnexal pain and mass. CA125 is elevated. If all four of them are ovarian lesions, can I say CA125 will be elevated in all the four lesions? Yes, it will be, right. And LDH was marginally elevated, right? We'll come to this LDH soon. It was marginally elevated. The patient CA199 is not elevated. In which of the tumors do you have CA199? Which cancers will have CA199 elevation? Where it is used as a tumor marker? CA199 is a tumor marker for pancreatic tumor, right? I'm not going to suspect any metastasis here. So pancreatic marker is normal. So it doesn't it's not fitting into my ovarian mass. So we'll ignore that for now. It's operated and the biopsy is shown here, and the gross imaging is also shown. So my entire diagnosis is based on my gross image. So here, when you look at the gross image, is it a solid mass or a cystic mass? Because that's more than enough for me to come to a diagnosis. One, definitely a solid mass, right? I'm sure all of you will agree for that. Second part, is there any gross areas of hemorrhage? Like, do you see very hemorrhagic areas, or it's just pale, non-hemorrhagic? I don't see much of hemorrhage there, right? It's not overtly hemorrhagic, right? Much of an hemorrhage. Solid mass with not much of hemorrhagic areas. I'm writing HHIGC for hemorrhage. So that's more than enough for me. Now I'll look at the options and see what will be the right diagnosis. I have not even gone for the microscopy. It's just few informations from the gross image. Zoom it out. Teratomas. You must have definitely heard teratomas or dermoid, whatever you call them. You must have used the term mature cystic teratomas. So you must have heard that. So teratomas must be and will be cystic. So it's not a possibility. Teratoma is not a possibility on gross because most of the teratomas are mature cystic teratomas. In women, most of them are mature cystic teratomas, right? Undoubtedly, so that's not a possibility. Second, for a papillary serous cystadenocarcinoma. So there are 2 points against papillary serous cystadenocarcinoma. One of them is I don't see any grossly papillary-like projections or a very friable mass. Any tumor which has the term serous tumors will again be cystic. Keep this in mind. Most of the serous tumors will be cystic. I don't have any papillary excrescences on the gross, and it will be cystic appearance only. Next, choriocarcinoma. If there's a patient with an ovarian choriocarcinoma, first of all, it's an extremely rare diagnosis. If it is an ovarian choriocarcinoma, my clinical history should have had beta HCG elevation. That's not there, but still, choriocarcinoma will be extremely hemorrhagic because made of the placental tissue to be hemorrhagic, right? So just based on the gross appearance, it's not teratoma, not papillary serous, not choriocarcinoma. So these three options are ruled out. The only one fitting in for me is dysgerminoma. It's just a dysgerminoma. The gross appearance, you can in the microscope you can see that you have tumor cells with clear cytoplasm. That's definitely there, and you have lots of lymphocytes here. The lymphocytes in the septa is also a classical finding in seminoma and dysgerminoma, and you have tumor cells with clear cytoplasm. Then with two leading questions, and I want you guys to answer. Why is the cytoplasm of a seminoma or a dysgerminoma clear? What are they made of? What are they made of? Why is seminoma and dysgerminoma clear? They're made of glycogen. They're glycogen-rich cytoplasm, which means they'll be positive for PAS. So if you have a question saying a testicular or an ovarian tumor, where the tumor cells are positive for PAS, think of a seminoma and dysgerminoma. Right? Second thing, What do you think is the role of LDH in case of an ovarian or a testicular tumor? Will it help me to come to any diagnosis or not? The role of LDH in ovarian and testicular tumors. Will it help us to come to any diagnosis? They don't, right? The LDH role in ovarian or testicular tumors help me to come to a diagnosis of a teratoma or a dysgeminoma or a granulosa cell tumor or nothing of that sort. The only role of LDH is LDH tells you the tumor mass. It doesn't help me to come to what subtype of tumor it is. It'll tell me about the tumor mass. If the LDH is very much elevated, I think it's a very big tumor. The LDH is moderately elevated, a smaller tumor. That's all. And if the LDH gets elevated after surgery, I suspect metastasis. LDH more means the bulk of the cells are more, the tumor is a big tumor. It doesn't help me to diagnose whether it's a dysgeminoma or an Yolk tumor or your choriocarcinoma. It doesn't help me like that, right? So here it just correlates the tumor mass and it's not going to help me pinpointing the microscopic diagnosis. Fine. We will call it a day today. We might have few interesting discussions in tomorrow. I'll try to host a couple of relaxing just to talk to you somewhere sometime tomorrow in Unacademy. So you will do well in the exams. Don't worry about the exams. Exams are definitely easier. Just be relaxed. If you're a bit far away from the center, I'd say go a little bit early. Keep 20th May, that's tomorrow, at least by 10 o'clock, not beyond 10. I would say even before 10 also is good for you. So, Lord Wish, don't worry. You will definitely do well. Right? Whatever you made mistakes here, it's completely fine. We take it the real exam. You know why you made a mistake. Just want you to apply in the real exam. Don't do a mistake. Great. Thank you for your time. I hope I have best wishes and prayers for you for the upcoming NEET exam. Do well. Thank you.